Good afternoon, everyone. Hope you're good. I know I said from yesterday's show that I asked, "Did you miss me?" And I've had a few people said yes, and a few people said we've missed you, but not how loud that bloody intro music is, which still continues to irritate, and I continue to not have the time to sort it out. So sorry about that. But yeah, I'm Jack Chew. This is Chewing It Over, 12:30 till 1 o'clock weekdays, and we discuss whatever's topical in MSK practice, in healthcare, and where culture meets it. We've got an interesting show today. I always say that, don't I? Because they're always interesting shows. But this one is a bit different in that Michael Schumacher, who you should have seen we used to do Marketing Monday more frequently than we do now, but he's been on the show a few times and he's our marketing lead and expert in that space, but then obviously non-clinical with it, but in touch with and speaks to a lot of physios all day, every day. But he then, instead of them needing him, he needed them. For a change when he developed neck and arm pain, I'll tell you all about. And so he then got that patient's eye view that he hadn't had necessarily before in recent times, at least. Otherwise I'm sure I'd tell you, been otherwise injured before, but don't get me wrong. But some really interesting insights, and there was definitely a lot to learn. I learned a lot from just him saying some of his reflections and how he sees us as an industry now, which is slightly different to before he had this experience. And so I wanted him to share them with you rather than me sharing it with you by proxy. So he's on the show today in a different capacity, which is cool. So let me do the whole clickaroo and get him on. As usual, please do let me know if you can hear loud and clear and stuff. That's really helpful, and for you to participate and join in through questions. We had some problems yesterday accessing some of the comments and questions and bringing them up on screen, which is a shame. So hopefully that doesn't persist, but the only way to find that out is for you guys to actually post them there. So hopefully, Michael, can you hear me?
I can hear you fine.
Brilliant. So as I've just said in the intro, a bit of a different circumstance for you coming on Chewing It Over. Usually we're discussing digital marketing and your specialism. However, today, still a subject you should know plenty about, which is your recent issues with pain and injury. So tell us a little bit about how that emerged, and then we'll get stuck into what that's meant in terms of your reflections for us as an industry.
Yeah, so just a bit of context. Obviously, you and I have known each other for years now, and we work with so many different physiotherapists. And marketing physiotherapists means understanding the patient, right? In terms of, what does a patient need, and what can a physiotherapist or chiropractor or whatever provide to a patient? And I've always been, pretty clear on that, or thought I was. And about, I don't know what it was now, 6 months ago, 5 months ago, I woke up and I had the most horrific arm pain and also armpit pain. And as usual, whenever I'm broken, I give you a call. You're my on-call physio. I think it was 8 a.m. on a Saturday morning, or maybe even earlier. And I'm like, Jack, I'm dying. What's going on?
6:35. Not that I hold you to it, but yeah.
Was it that early? Yeah. I mean, I was genuinely just this happened actually a couple of months before that as well. If you remember, where I was disabled.
Yeah, no, that was a weird one. Yeah, we're going to do that on another show. Let's not digress, because that was. But it's also an interesting example of how sometimes just having someone to call is important, isn't it?
Yeah, I think absolutely. For me, I'm so lucky now. I'm 44, just turned 44, so I'm obviously just breaking. So having someone to call is crucial. But that morning, I wake up and I'm just in such severe pain. And ordinarily, I'd probably have gone to A&E, to be perfectly honest. But knowing that I've got access to the best of the best, I didn't call them. I called you, and within about 2 minutes, you said, Michael, it's your neck. It's likely to be a C5, C6. This is what we need to do next. And the next stage was I went and spoke to, big shout out to Jonathan Bell, one of our friends and partners in a number of ways, who owns Wimbledon Clinics. Reached out to Wimbledon Clinics, got an MRI sorted, had a chat with the spinal consultant there, and then showed you the scans as well. And then the next stage was you pushing me to Mark Reed, who was at Choose Health, who was absolutely sensational. And it was a really interesting process, because the first and most important thing for me was the knowledge, the knowledge of what was going on, and understanding what the problem was, and getting an accurate diagnosis, right? And I think I was talking to Jack March about this earlier. Strangely enough, a week after this happened to me, my friend called me and he said, "Oh my God, I've got exactly the same thing." And I think I told you about it, and you said, "Yeah, nerve root irritation, no question." He went to a physio. I won't say which one. He went to a physio. The doctor gave him diazepam, and the physio was seeing him 3 times a week and massaging his neck because that was going to make him better. And the level of care was just completely different. And so for me, the great thing was having you say, yes, this is what 99%, this is what it is, need the MRI to check. And then having, that confidence, because I think pain is okay if you know why you have the pain. Pain is okay if you know what's on the other side. It's not okay when you sat there without any knowledge. It hurts and I don't know why. I don't know how to fix it. I don't know how long it's going to last. And so for me, the physiotherapy side of it, or the benefit, came from that knowledge. It came from knowing what it was. And then also Mark Reed, really, he was sensational, because once I started talking to him, it was very apparent that he actually focused on the drugs. He focused on the pain relief. And he talked me through the different drugs that I was on and what I was taking and what I might experience from those. And that then got into interventions, which was, in an ideal world, you don't want an intervention. You manage the pain, because this is a 3-month, all the research says 3 months. It's funny because I mentioned it to Adam Meekins and he said just drugs and whiskey is all that's needed. I didn't go that route.
And deadlifts, he probably said, didn't he? He probably
yeah.
said.
And a bit of acupuncture, I think he did. It was really interesting for Mark to say, what we need to do is get that balance right? Because I was on diazepam, opiates, to pentadol, gabapentin, and it was like, you're going to feel like crap, but we need to make sure that we get that balance right, because if we can get it, then you're going to be fine. Then you just ride it out for a little while. Yes, here's some neck tucks and some things that you should be doing, but again, having that knowledge was just invaluable. And I think, the reason we're doing this was that yesterday we were having a random chat about something, and I said that physiotherapists are just like solicitors. And you said that was quite a good analogy, and I'll explain that quickly. In that I have a solicitor. Before you
do, because definitely that is the meat of it, and we want to get there. Don't get me wrong.
Yeah.
And so we'll come back to it. But before we do, I just wanted to make sure I flagged something that I know some of my colleagues and viewers of this will be ringing in their ears. The fact that early doors we were eyes and imaging, because this is often it might seem cavalier to do so quickly. You had a fairly what was indicated as being a compressive lesion. We couldn't assess you in person because of the geography between us. You're in Wimbledon, we're in Manchester, but you were getting some overt weakness and effects into the limb. It felt like, therefore, we wanted to understand the extent of a compressive lesion, and that's why that was indicated. But I wanted to ask, so that's not just me sort of arse covering to justify that clinical decision, but I wanted to ask you on that, how important was that imaging for you, alongside and coupled with the assurances we were able to give?
It was really important, because I felt as if it's funny, because it's like there's something to look at, right? It's like an X-ray. Someone can say you have a fracture, but to me, as an uneducated, non-clinical person, what does nerve root irritation look like? Is my spine cracked into 15 places? And being able to see it was actually really, really interesting. And the other thing that was really important from the imaging was having the consultant afterwards looking at it and saying, yes, it's what we thought it was. Because my biggest fear was that he was going to sit there, and initially I thought this is what he was going to do. He was going to sit there and go, no idea. I've got no idea what this is. It's not what we thought it was. And we've got to start again. So the fact that he said, yes, Jack Chu, Mark Reed, they said that this is what we think it is. I've done an image. I can see that that's what it is. You don't need a fusion. You don't want to go for an injection at this stage. Let's go and let's let's go through the rehab and so on and so forth. So yeah, it was
because how much, it's hard to know in hindsight, but at various different intervals during your journey through this, and I'm glad you've come out of it. I'm so chuffed, because that was the likelihood, but equally it's never inevitable. These things can be really quite tricky and complex, and it really did disrupt your life significantly for a time. But at various intervals you were checking in and not in as many words, but you were saying, are we sure? Is there anything else? You just needed that repeat on the reassurance with it. Now, we speak so often on various different things, it was totally appropriate for you to do so. And I was asking after it as a mate and a colleague. But I wondered, without that imaging, do you feel that you would have been as likely or less likely to accept our assurances and things?
Yours, yes.
Right.
I would. You and Mark, yes. But then I trust you hugely. So you've seen it, you've done it, and I've seen your patient results. So yes, I'm not sure if I didn't know you. I'm not sure I would. If you were just a physio that I'd gone to, I'm not sure I would. And just as a side, diagnostic ultrasound is something, when we're marketing clinics that have a diagnostic ultrasound, it actually works incredibly well in terms of a patient going, okay, I know that this person is accurately diagnosing me.
Right.
Again, clinically, that's not, whether you should use it or not, I don't care about that stuff. But from a marketing perspective, certainly as a patient, this is why all the dodgy chiropractors do X-rays, right? Here is something that you can see. So
that's why it's compelling. But this is the challenge, because the over imaging is a problem. And there's a really lovely recent paper. I'll try and find the link. I wish I'd have thought of it to put in the chat for now. But it's like general practice, proliferation of MRI in general practice as a means of there is an over imaging process whereby it's not changing management, a lot of depletion of funds, as well as then over attribution to structural causes for people. And what you had was the ability for us to constantly, and several professionals able to clarify what was and wasn't relevant, and offer an appropriate assurance that these things that were indicating as to why you might be experiencing these symptoms, the reason why those things don't need to be structurally corrected for things to alleviate, right? So that was one of the things that really mattered there. And I think that sometimes if you only have part of this journey, it can go awry, but as a package, it can work quite well.
Yeah. And just going back one step as well, I remember right at the start, because I was like, look, whatever I can do, I'll take an injection today. If it costs me 100,000, I'll do it, because the pain was so severe. And you said, go and watch my podcast. There's an old physio maths.
Oh, that's right. I did.
So because you were like, listen, that's not what we do. We don't just inject people. Chill out. I've been through this myself. Go and watch this podcast, and you'll see it talks about interventions and what happened to you, and why you disagreed with the surgeon. I remember there was stuff around, the consultant was saying something.
So for those that don't know, this is a few years ago. I had a lumbar spine problem, not dissimilar to Michael's. Frank weakness, lost all power in my hallux, had a pseudo foot drop, and went on to need a decompression over time. But the timing of the interventions was one of the things that was kind of laboured within that podcast. I was interviewed by my then boss at the time, Paula Deacon, and so an interesting podcast. Again, we'll put a link in. But I said to Michael, even though it's a different body part and stuff, just listening to this experience, and also I wanted him to know that, as much as I was trying to labour the point that, God, I feel your pain, mate, I was wanting him to probably, because it was before we knew each other, I wanted you to hear about the fact that I'd been there and that.
Yeah, because I wasn't aware of it.
It was savage. Yeah, it's good. It's good that you weren't aware as well. It's good that I don't bring it up in every. I'm glad that I'm clearly over it. That I hadn't raised it.
Do you know what? It was just that entire process was interesting, because because I did get some really bad advice from people, because obviously I know a lot of people in the industry. And
you were on Zoom calls, like on your sofa at a funny angle, and you were having to explain yourself. I remember we were in some business meetings, and we were all like saying, before we start, let's just explain why Michael is at a funny angle on screen. And that's one of the things I wanted to ask you about, is tell us about what you were told by others, and how varied was the advice you were given outside of our stuff?
So the people that I know generally are customers, and we tend to have customers who are 99%. No, in fact, you know what? All of them, they're genuine ethical physios. We don't, we had someone contact us recently to market IDD, and it's like, no, not happening. So we have a lot of good physios, but there was certainly advice which wasn't consistent. And I found that the majority of the advice was consistent. This is what's going to happen. This is what it looks like. This is, but every now and then there was some advice that just wasn't accurate. Or no, let's not say accurate, because I don't know that. Let's say it wasn't consistent with what other people were telling me. One person told me to do an exercise until it hurt. Like, do this particular thing, and when it hurts, you know that you're getting some good results from it. Now, unless you get pain in your leg. I mean, it was something that was completely crazy, but it wasn't consistent. So I think for me, it was a case of throwing away anything that wasn't consistent or didn't adhere to what everybody else that I really respected was saying.
Were there a lot of people suggesting like this particular style of treatment, like
yes,
this massage, this manipulation, these needles, this tape, this laser, like what?
Yeah,
was it very interventional, or was it management tactics?
No, there were some very specifics around the type of acupuncture that was going to be effective for this. It wasn't normal acupuncture. It was something I can't remember. I ignored it. But in general terms, I have to say that yes, there was some bad advice, but most of them, it was quite funny because it was such a big thing for me and such a massive issue in my life, and everyone was just blasé about it. I remember there's one guy. I'll shout him out, Tom at Flex Physio in Oxford, really good guy, and he was like, "It's fine, you'll be over it in 3 months. Just chill out. This is not a big thing. No, you don't need operations." And so there was a lot of that, which was like, listen, like it almost felt like I had man flu or something. Chill out.
That's a really good. But I never thought that we'd end up here. But I'm going to ask the question now: is how much of that was in the right circumstance reassuring that people weren't hearing your story and weren't like overly worried, and how much of it felt dismissive?
No, really reassuring, and no, I didn't feel dismissed at any point with people. To some extent it was jokey because we have really good relationships with our physio clients.
That's the thing, is that it does overlap. There's such a difference there, isn't there? And Anna's posted here. I'm going to bring some comments up and questions in a second, but it was such a big thing in my life and everyone was so blasé about it. It is powerful, and that can go badly or it can go well in that if it's appropriately couched in the right circumstance and in a bit of banter and within a relationship of which it can be assuring. It wasn't necessarily well,
what I would say on that is that I knew that these people cared, and when someone cares and they're blasé, you're okay. You feel like, like I don't want to say Adam cares about me, but his just drink some whiskey. I knew that he's the sort of person that isn't going to be an absolute dick and just want me in pain or not want me to be okay. And so when someone, the same as you, like, you were quite dismissive about something, and this was another interesting thing. I started doing Google searches, right, as you do. So I diagnosed myself with spinal cancer, and I actually sat there thinking, God, I've got spine cancer. And then it was like, and I actually messaged you. I was like, listen, I'm really worried. This was before the MRI. I was like, I'm really worried. And you were like, just shut up. Just no, it's unlikely.
Yeah, I mean, this is interesting because you're always going to remember the details closer than I am. But it was me trying to then say, you'd looked at what if I've got spinal root compression, what can cause that, and then you're describing what clinically we'd say are space occupying lesions, most commonly a disc. The people, you get a narrowing that means that you've got this thickening of the ligament, less so in the neck. It just becomes smaller, it's arthritis. But then you have got space occupying lesions that are tumours or growths or other cysts and rarer things like that. And because they are then named on a WebMD style list, then you were concerned in that direction, and the imaging definitely helped us in that direction. But also, I was able to appeal to the rationalist that I know well, and was able to say, well, let's talk about raw probability. I think even we went to, didn't we, and said, well, of course
we
it could, but you would be typically presenting with these sorts of signs. It's unusual, it's very mechanical, the way it's emerged, you know, and that again, it's this waxing and waning of your reassurance that seemed to be occurring, which was a very natural process that we witnessed with patients. But we were in such regular communication, like we would normally. I'd be speaking to a patient about this weekly or fortnightly over a course of time, and then they might raise concern over the phone or on email and stuff, and we get that. But we were speaking, you know, a couple of times most days at the time, you know, because of various things we were doing, which meant that I was able to check in, and that can sometimes be for good and for ill. And so, you know, I look on at that as being, there were times where I think you had too much access to healthcare because you almost, or too much access to advice. Like, do you disagree with that?
I disagree. It was just really reassuring because you know, I can't stress enough how much it affected my life. You know, I mean, it was bad. It was so bad. The pain, the drugs as well.
Goes you sleep. Well, the drugs, because that was the thing that we had a lot of kinship on, wasn't it? The way that the drugs, especially your gabapentinoids, they'll slow your cognition, and me and you are often trying to creatively solve problems, and we kind of build our working life around that sharpness. People will disagree whether we're sharp or not, but we're trying to be, and that made a massive difference. Didn't it? That grogginess was as bad as the pain in many ways.
You actually commented not so long ago where something had gone wrong or something we were doing wasn't quite right, and I was like, no, that's because I get things right. I'm sharp. I get things right, and I'm there. And you said, well, actually, Michael, no, you rely so much on your memory and so much on being analytical, and you were not that at all. And it was really interesting.
I know, I remember saying that, and I can't remember what it was about because we've clearly got over it. But yeah, there was definitely a time where, and it's no fault of yours, but it was just that you have got a cracking memory, and I don't have that, and so I know how I compensate for it. And because you were sluggish around that time, it meant that there's a couple of bits that slid. Nothing dramatic, fortunately for us all. I want to get back to, though, I've digressed this quite significantly from this point about solicitors, and so I want to get you back there and let you just run with that, because it is a really interesting analogy. So what do you mean by that, and how has it then changed your perception of how we're best positioned and placed in healthcare?
So that's the thing that's really had an impact on me is how you position the physiotherapist in healthcare and to patients, because it's always been traditionally fix the problem. I have a hurty knee. You go to see a physiotherapist, sports therapist, they will fix the hurty knee. I'm not sure that that's the right way to be focusing on things, because I think knowledge is power. And like I said earlier, pain is okay if you know why you've got it and you know the solution to it and how long it might last. The reason I brought up solicitors is that, you know, as a business, we sometimes have legal issues, things that come up. I've never gone to court. My solicitor has never, ever taken me to court and actually done something for me in that way. But he is always there to reassure me and advise, tell me whether I should be worried, tell me what I could do to help, you know, what I could do and things not to do, and what sort of insurance to get, and all of those sorts of things. So it just struck me that whenever I've used a solicitor, it was very similar to how I used you and Mark and the other physios I know, which was very much about reassurance and knowledge, and not necessarily doing something that will fix a problem. For example, like my friend who went to a physio who said, I can fix it through, you know, massaging your neck. And so that's where I came up with that solicitor analogy. It was that physios and therapists in general, a lot of it is about communicating effectively, giving people knowledge, helping them understand what the issue is, and giving them ways of dealing with it. Whether that's like Mark Reed with, let's look at the drug side of things, or you're a runner, that doesn't mean you have to stop running and sit down for the next 6 months. We can use running as rehab. I saw Tom Goon earlier message or tweet something about this, which is get a runner running when they're injured, because you can see what's going, you know. So I think that's really, really important.
Yeah, absolutely. No, it is a great analogy, because it's this idea of of that. Solicitors don't use this language, but it's this minimum necessary force, isn't it? It's like let's work things up. Let's make sure we're thorough. Let's understand it first, which obviously is then the solicitors, their analytical side is incredible, especially the way that they can pore over what look like the same words and jargon, but they kind of get that analysis right, and then from there it's like, right, what are the minimum necessary forces for us to get to the outcome that we need, that is for justice, you would hope, and in this instance being what is it? What's the typical time frame and trajectory? And what are the forces at play that might affect Michael's recovery? And then making sure we're not haphazard with that, because it is tempting to jump for more profound and significant interventions than are necessary. Now, sometimes they're necessary, like the act of going to court might happen in the future if that necessitates, because the context means that it's needed. But most of the time, not. And that's why I do think that's a really strong analogy. But it takes for then, and one of the things I wanted to talk to you about is, if that is the way in which you now see quality MSK care, of which I agree, of course, that takes for expert assessment and communication and a management that is very much made individualized and bespoke and personalized in every which way. And it's less intervention laden, isn't it? Do you think that are we well on that way? And do you encounter most people that are that way out or not?
I'd tell you what, it's funny. I think you are on the way. I think it's what you do. I just don't think it's how you market yourselves. You market yourselves as, you have a problem, we will fix it. And from everything I see, again, every physio that's a client, or I keep saying physiotherapist is a client, you talk to them and they're all exactly the same. They give the same consistent advice. And this is what I do in clinic on a daily basis. But everything from their digital footprint, let's say, is all about, I fix people. You have a sore back, you have lower back pain, come and see me and I'll fix it. None of them actually believe that they're going to do something. It's about, okay, let's talk about why you've got it. Do you know what? Unfortunately, you're 60 kilos overweight. Let's work with you on that. That's probably going to help you. That's what physios are, or what my clients at least I see are doing. So it's not, I don't think you need some step change here where physios suddenly have to do this. I think you all already do this. I think it's about communication to the patient, communication with the patients outwardly to say, this is actually what you're going to do. And I think that's the key thing.
Yeah, well, that's one of the. So I agree with that. I think it's probably that I certainly am in contact with, from our list we engage with most. It's a hell of a skewed sample of the norm, and I think that you have a version of that as well in business and the practices you decide to work with are on the ethical side of that spectrum. But I think we are moving that way clinically, but it's just how we message that and how we can get cut through with the patients so that they can expect that, and that change in market force and market behavior that can mean that people don't then decide to say, here's a list of body parts I treat, disembodied from the person, and here's a list of interventions that we do to fix said problems and body parts. And so people feel almost obliged that is the industry standard. And the only way that we can really try and do that is that the market forces then mean that they're not wanting that, they're not needing that, they're not responding to that style of advertising, and therefore the perception shifts over time, which is obviously music to our ears. I don't want to duck a question because I'm not going to get to all the questions and comments. Sorry for those that are posting, but I wanted to make sure I didn't duck this one. It came in fairly early, Martin Davies, when I was talking about it being a compressive lesion. Does that mean you would image all compressive nerve roots? No. There would be circumstances I wouldn't. There'd be circumstances I would. However, when in this instance, whether something is compressive and you have what are considered loosely hard neuroscience, disrupted reflexes, of which we couldn't test in Michael, for example, in person, but certainly overt physical weakness and sensation changes, and the trajectory of those is certainly going to influence my reasoning significantly when it comes to imaging requisition, in this case, MRI. So it's not a blanket rule, for example, Martin, if that's what you're asking, that if something is indicated as compressive, I would, especially a lot of cases like this where we're consulting someone whose weakness is definitely on the turn for the better and was fleeting, then that's certainly an area where I wouldn't. But you'd always keep it under monitoring. And I think that one of the things that we're dealing with when it's compressive is the fact that you are at risk of cell death, for want of a better term. you know, the way in which the nerves is that you know that if they are compressed and then trapped, as is often the language used, then that is something that for too long a time, then you could lead to a more profound paralysis. And so you want to make sure you get across that, and it's safe to do so, to make sure you don't delay imaging for too long after those things. So not a blanket rule, but a very good question, a fair one. And I hope I've answered it reasonably, but I did need to just get sucked into the clinical weeds for a second there, Michael, just to make sure I didn't duck it. Is there anything else you want to add before we wrap up on this, from your experiences? And but you kind of, it sounds like you, in general, have had a positive one. Is that a fair summary?
Yeah, it was in general really positive. The worst part of the entire thing was you had said, this is what it is, go and speak to a doctor, to a GP to get some drugs, essentially, because you can get prescribed something. They sent me off to hospital for a heart attack. Which was quite amusing.
I forgot about that.
So I spent all day in hospital having heart tests, and my blood pressure was high and my heart rate was high because I was in bloody pain, to be perfectly honest. And then finally the consultant came out and he said, "Are you a physiotherapist?" And I said, no, I just happen to work with a lot of them. And he said, "Oh, okay, yeah, no, it's not a heart attack, go home." But yeah, that was quite amusing.
I forgot about that. Yeah, we see that sometimes. Really intense pain skews your SATs, as well as then sometimes like costochondritis or other things that make you short of breath or painful, and especially the arm pain. You can kind of get it why people clutching their arm, and you know 111 or a GP sometimes then react badly to that.
There's one more thing I want to just leave you with, and maybe it's a discussion for another time. It was okay. The physiotherapy side of it, I got as much use from you as I did from the consultant who did the imaging and looked at the imaging. And in fact, you looked at it and you came up with the same thing. What was interesting was that a physiotherapy appointment would have cost me £60, £50, £40, whatever. An orthopedic consultant for 30 minutes on Zoom was £250. There is an interesting thing there for me in terms of what a physiotherapist, because you both did the same thing essentially, but the orthopedic consultant was happy to charge £250, the physio was not. So I wonder whether there is something to be, well, at least it's something to think about.
Well, it is, but it's happy to charge, and that's the thing, is that I've
and happy to pay.
That's the thing, is that social association to it, because especially because it's easy to say that in hindsight, isn't it? But your perception may well have been that you were getting a level of expertise beyond, and in the surgeon's defence as well. As not that we need to defend him, because we're not for a second suggesting it wasn't a good intervention. But the price differential is somewhat skewed by the actual level of professional governance and training that they go through. And so you end up in this situation where they have ended up on a accredited level, at consultant grade, and have gone through a process of that postgraduate training that is inevitable. Whereas within physiotherapy, it's sort of naturally self-regulated. And for my example being, and it's kind that you're putting me on that pedestal, but it's just that on a specific training level, then I am no more qualified than my undergraduate. So,
for what I would say from a patient perspective, I would have been more than happy to pay Mark Reed £250.
You still can, now you've mentioned that.
Yeah, okay, I'll send you some money. But I would have been more than happy to pay £250 for that, because that advice was absolutely invaluable. And actually, this is a whole nother topic, which we'll get onto at some point, I'm sure, which is pricing and charging in this industry, and how some people who have, chronic pain like me, charging them such small amounts when a hairdresser will charge you 400 quid for a haircut is out of this world.
I think that's a really good point, and definitely one we need to pursue, and one for another day. Really pleased to hear of positive experiences, especially those that you attribute to us, especially Reedy. I agree with you, phenomenal clinician, and completely because he's got a gobshite like me making loads of noise all the time. He probably people don't realise, and I maybe don't say enough, just how brilliant he is. So I'm glad you had that experience, because he is brilliant, and that above all else, that you've been able to share some of your insights from being that side of the advice table, and I think it gives some sign that as well, we've not met in person since it happened, and so all of these positive health interactions have been virtual for effect? Apart from, you did go in, of course, to actually you didn't have a scan over Zoom, and you did go in to meet the consulting person, I understand, didn't you?
No, I just had the scan.
Is that
consultant was Zoom.
Yeah, that's great, apart from your A&E attendance. So, which was a fascinating thing, especially when it wasn't appropriate in COVID times as well. So that's another thing, isn't it? So yeah, let's leave it there because we're in overtime. But massive thanks for sharing that with us all. It's decent, and I think the way that this will inform our usual style chewing it over is about marketing and value and things like that. I think will be interesting. No doubt we can hark back to this story again. Because it's been really interesting. So thanks a lot, everyone. I'll be back tomorrow, and we will finally be, I'm over it enough now to talk a little bit about the football. And so tomorrow's show, we're going to be talking a little bit about that, about the cultural phenomena that was the Euros as well, including the good, the bad, and the very ugly that has unfortunately emerged from it as well. That we're going to talk about on tomorrow's show for Friday. So do join me for that. Looking forward to it. And thanks again, Michael. We'll speak soon. Cheers, mate.
Cheers.